I'm going to rotate it through, and I need to be able to pick the needle up without damaging the potato. So what about this position? Okay, going around the circle. That's at 9 o'clock, that's at 8 o'clock. How am I standing in this position? So my weight slightly shifted to my right foot. Coming around to 7 o'clock. Same again. Place, point, and rotate on the line. Coming around to 6 o'clock. And I'm now almost standing on my right foot only, 95%, 5%. And I've turned sideways to the table. Then I come to this position, and I find myself leaning further over the table, abducting my arm even further away. And now my rotation is becoming slightly awkward. However, when I come to 4 o'clock, in this position, my arm is really abducted. I have to lean across the table to reach that position, and it starts to feel very uncomfortable. And you can see I start to lose control of the needle. This is one of the most difficult stitches to do because I am stitching as a right-hander into my right shoulder. And it's in this position, before I take the next step, to 3 o'clock, I am going to change my weight to my left foot and bring my left side to the table. I'm going to deliver the needle on the curve, backhand. I can now continue my journey around this clock, and I need to practice backhand. And as I do this, coming in and out of the potato, I'm thinking, am I equidistant? And am I taking it out carefully on the curve without damaging or tearing the potato? There you go. That was 2 o'clock. The 12 passages of the needle through that same hole, the potato is getting a right mashing. Now I'm coming up to 12 o'clock. There. And I have to think about the alignment of my needle and think about the rotation through the tissue. On the line, equidistant from the edge. Oops, and you can see there, it's now becoming a little bit awkward, and I've just torn the potato. Let me take it round. And this is the common area when you're coming around any anastomosis, where it's likely that you're going to cause damage. So that's 11 o'clock. And now I'm backhand again, but I am standing on my right foot with my right side towards the table. And now I'm finding it very difficult to control the needle. In this position, what I should be doing is actually thinking, I've lost control of the needle. And what I need to do now is perhaps go forehand and repeat the exercise from here. And I'll switch to forehand. So I can either switch forehand and backhand by leaving the needle in the tissue. That was 10 o'clock. Let me get that bit of skin out the way. Leaving the needle in the tissue or pirouetting the needle over the top. I'm just moving off center, and I am off center because the potato there is getting worse for wear. Okay, so I'm going to come parallel to that. And out, equidistant from the edge, 90 degrees across. But I hope you noticed one thing, but across this position there, between 11 and 10 and 5 and 4, I had to switch my body weight from my right leg to my left leg. I also had to change the angle of my needle. And this is where this pirouetting over the top becomes important. And you can seamlessly move around the table and move your needle from forehand to backhand as such. Now, the interesting thing about the potato is it's going to now challenge you in many other ways as well, because it is hemispherical. Okay, there's a side on the top, there's a side there, there's a side there, there's a side there, and a side there. And if you draw lines on your potato, you now got infinite possibilities. And what is useful in this exercise is for you to work out yourself what position you are going to stand in to effect a stitch. So let's say I'm going to put a stitch in here. And as I do that, I have to bring my elbow up, and that's why you can't see the needle, because my hand's in the way. But note, because the wrist is no longer displaced significantly from the elbow, that angle is significantly reduced. And the alignment, though, is exactly the same. Place, point, and rotate. Place, point, and rotate. And what we really want to be able to do is in each position, can we effect the stitch forehand and backhand in each part of this potato, ensuring that you're equidistant from the edge and you're not mushing the potato at all. You can turn this any direction you like to test your position. And the fundamental is this 90-degree alignment. Ensure that first, and then work out for yourself your body position. How are you going to stand relative to the table? And where's your elbow going to be? Do you have to abduct your arm? What about this side? There again. There. Do I do that as a forehand or as a backhand stitch? There. Can I do it as a forehand? Well, I can do it as a forehand if I mount my needle correctly and point, and I'm rotating it as I'm using a screwdriver. And I've lost the rotation of that. I could feel that rotation lost as I went through. And what's interesting, chatting to Mahesh the other day, who's making significant progress with his stitching, he can actually feel the needle deviating as he's going through the tissues. There you go, delivering it on the curve and trying not to get the potato. This angle here down the bottom is not too dissimilar to the one that I frequently came across in cardiac surgery, because the aorta would be there, coming down, right atrium would be there, and we've done an oblique aortotomy like that to get into the aorta. And we have to close the aorta in this position. And one had to get the elbow up in the air and do a reverse backhand screwdriver stitch through the aorta. And this is one of the thinnest parts of the aorta and one of the most unforgiving, to get that screwdriver stitch through without pulling out the potato. So as we're doing this, this model here is inviting you to test and try how to place yourself in the right position to make the right stitch. And you've got infinite combinations as you rotate this potato around. And I would recommend that you use lines, because that is helping you think about your orientation and your 90 degrees. Because next week, when we translate this into stitching, bow or vessels deep within a body cavity, you've got to be able to effect the perfect rotation of the needle in every position and ensure that it comes out cleanly like that and equidistant from the edge. Some of these are not, but each and every one of them has to be. On this occasion, there we go. They're all on the line, and the distance from there and there was the same. Actually, that wasn't on the line. It depends if you play rugby or football or tennis. But compare, contrast, please. Say no more. So not only is it giving you haptic feedback, but it's giving you a visible response. The potato in baked potato is extremely soft, and you can see that the skin tears with the lightest of touches. I can almost scrape it off. But what it's doing is actually ensuring that your rotation is completely perfect. So it then comes back to how do you stitch the banana? And the answer is very simply, carefully. I'm going to use a smaller needle. Here, I've got a smaller needle, I think. There we go. The great thing about these exercises, note that I'm not using lots of sutures. I'm recycling all my needles of different sizes for different practice. So I don't have to have a huge number. Remember, the thread follows the needle. So the basic principle of all stitching, therefore, is stitch towards yourself at all times. And if you're using a continuous suture here, then you'll not be tripping over yourself. And the important thing is also to ensure you use, I'm going to use the diameter of the needle. And this is a fiendishly difficult exercise, as many people would attest to. But again, in the placing, I'm using the placing aspect. I'm checking the pickup. I'm using the placing to ensure that I'm radial and at 90 degrees. Then having placed, I can space and I'm rotating through. Place, and I've losing the control of the needle there, so I'm not going to effect the stitch. Every time being mindful of my position, and if it's not correct, I actually deliberately correct myself. I've got a curve of the banana there, which means this equidistance from the edge is going to be awkward in that position. But placing to think that I'm radial, I've lost control of the needle there again. Coming out of the curve, picking the needle up. Remember, this is the position. I need to think about, am I going to go forehand or backhand in this position? Or am I going to deliver that needle out, swap to my left leg, deliver it carefully out, iteratively on the curve, and pick the needle up so it's ready to use backhand at the next stitch. And anybody who's actually tried this, and this is the, as I said, the black belt skill. That was too far. I'm taking that out and placing that again. And what I've noticed also, just going to drop the needle, what I've noticed is that when you go backhand, I can usually tell if somebody's forehand or backhand, right-handed or left-handed, because the switch between forehand and backhand, the spacing disappears, the radiality disappears. Right, beginning. There, that's fallen shorter, I think. Yeah, okay. I haven't quite got a space there. But we've gone round, we haven't mushed the banana, and we've got to look at are the needle points clean, exits, simple points, equidistant from the edge, and radial. It is a fiendishly difficult exercise. And that's why we've set it as a black belt skill. Sensei Kari, myself, and Sensei Sujaya with Finish and Akash have come up with a scoring system with an interclass correlation of 0.97. And this is that scoring system that we are going to put online, together with the linear scoring system. You can see in both cases, we're getting more information and more learning from the practice of something that is akin to human tissue between 40 and 80 Hounsfield units, compared to taking needle through this thing, which you have to force the needle through. Look at it actually pulling as I'm trying to take the needle through it. And I challenge you to spot where the needle went in and out on there. You can't. I'm sorry, but this is not a useful tool. And I'm having to drag the needle through that. Tissues, you don't have to drag the needle. If you use the needle correctly on the curve, there's no dragging or moving whatsoever, as in here. The ideal cert model is this, because it gives you the haptic feedback and it gives you the visible effects of not placing properly and not pointing properly. Not only that, we have a model that at the end of a session, you can actually eat. You can't eat suture pad. I have for you one more skill. And this skill I have reserved for second dan skill. So the black belt was going round the banana. The second dan is going round as well, but this time the focus is on the entry and the delivery of the needle rather than the exit. So let me introduce you to this model. You've got it. It is a poached egg. Now it's round. I need a small needle. And I'm just thinking, where's my needle gone? And we'll now take the needle, and I hope to demonstrate to you. And this is a wickedly difficult exercise, but I need to take my needle into the space between the yolk and the white. And I need to rotate my needle through cleanly all the way through. And I need to deliver it through on the curve without leaving any marks on the egg. So there you go. Take the needle through the white of the egg. And this exercise is a fantastic exercise. See there? It's starting to tear the the yolk. And this is certainly focusing skills and asking you to think about how you use needles. So I can, even on the surface, flip between forehand and backhand without damaging the egg. So there is a perpendicular dive into the water as seen by the Chinese diving team, and I'm rotating it cleanly in. And I should leave very little in the way of splash as I come out, going round in regular fashion this egg. So if I drag it through, and I'll demonstrate to you the effects of not doing it very well and coming in at the wrong angle and doing it, see that I'm starting to scramble the egg as opposed to 1, 2, 3 clean rotate entries. Now that is a dirty entry. So organic models are giving you testing and reinforcing the rotation of the needle. This is extremely soft tissue. The only time I've come across tissue as soft as this, I would say, is a dissected aorta, where the tissue is as pliable as this. And you can see if I do it difficult with hard, it tears out. Using these organic models is offering you an opportunity to explore your needle control, your needle handling, your handling of the instrument. And to be honest, I find them very engaging. I could spend hours here practicing and going around. And really what I shouldn't see is egging my forceps either. But you can see the difference between good and clean entry. So that is my offering for this evening on Round and Round, and reinforcing that the round in the shoulder is there, but the round with the needle is holding a screwdriver, and that is the round and the rotation. The trick is to get it perfect every single time, because tissues, anastomoses, polyanastomoses, vascular anastomoses, microsurgery, the principles are the same. Now, how big or small the needle. And just because it's deep doesn't mean to say that you should not be aligning your needle without the dislocation, align from the edges so you don't see the slip. Because this is the fundamental of stitching. Equal and opposite, no dislocation, equidistant from the edge, no slip. That is what stitching is all about. Now you know how to align the needle. Well, I've offered you a number of different models for you to practice, but you can't jump in at the boiled egg. You have to learn to pick up the needle and use your needle holder and understand the rotation. And it's only with practice then you can start doing these. As I'm learning, to be honest, with my sword, I thought I could do it well. I now understand I can't. And there are simple things that I've taken for granted that even on Sunday, that I've realized for the first time in my 5 years of Aido that I was doing wrong. And you don't know what you don't know until an expert actually points it out. The sensor can determine a deviation on my blade there, and you can kill me. But that's in your line of vision, and you can't. He can spot that from the end of the room. And it leaves me wondering about training in surgery in general. Are we paying the same amount of attention to how we hold instruments and how we rotating our needle? And with that, I'd like to actually ask my fellow senseis, Silek and Chris Caddy, to join the conversation and join the round. Comments and questions.
Well, David, as always, another masterclass. You got your poached and hard-boiled eggs a little bit mixed up there.
Yes, yes.
It's not a poached egg, which would be almost impossible.
Well, yeah, no, the poached egg
It,
I actually used for the 7 O's in the
yeah,
arteriotomy.
but it's a hard-boiled egg,
Hard-boiled
and it's
egg.
still
Yeah.
very difficult.
Yeah, and you can see yourself the needle going in
Yeah.
clean. It's quite obvious, and it's a
And I think
challenge.
when
That's why I
when
call it the
people
second Dan skill.
when people are going to try it, they need to make a jig that will hold the egg so it doesn't slip around as you're trying to do it.
Sure. Or you can gently hold it with your fingers. Yeah.
Yeah. But that's about using an assistant.
Yes.
If you have an assistant, it's about
Yes.
setting yourself up for success,
Yes.
being situationally aware and thinking
Yes.
about what's going to happen if I do this.
And being aware of the circle around you, the circle of people around you. You can't do it without a complete circle of people. And that's part and parcel of what we try and teach in the Black Belt Academy is there's more to surgery than just technical skills. But if you master the technical skills from an early stage and get them, then you can actually master, when you reach theatres, the necessary non-technical skills, which quite frankly, probably, well, are more important.
They also take a lifetime to master,
Indeed.
as do the basics. But
Indeed.
this is all about continuous improvement. It's about
Indeed.
getting better every time.
Indeed.
But in order to work with that, you need somebody who will critically look at what you're doing and say, yeah, that's absolutely brilliant, but how can you do it better?
Correct.
Because it's just like you holding your sword, you can't see the way that you're holding it.
Correct. Correct. It's interesting. I was thinking the other day because the dojo has mirrors down both sides. So as you're practicing, you can see yourself in the mirror front and back and look at yourself. And I was thinking that our colleague Ria Lang in Australia, she's a dancer, and dancers actually dance in studios with mirrors. So you're getting feedback and reflection of your body position and things. And I was thinking, well, reflection plays an important part of your role in the development of the surgeon. I wonder, is there any way we can reflect on this? And you could do if you were taking a video and then looking at it afterwards and critically analyzing it.
But what you have to remember there is that the mirror is a reflection.
Correct.
And so if you try and do something in a mirror, it's almost impossible. So if you attempt to draw a star
Mm,
using a mirror, you will find it very difficult. And what you
yeah.
then need to do is to learn how to adapt to that situation so that when your hand is going to the right, it's actually going to the left.
Yes.
And it's
Well, I
a
suppose,
very complex
and that's
skill to
that
learn
I
to
suppose
do.
is part of laparoscopic surgery, isn't it, really?
Yeah.
Is the opposite movement. Um, so I haven't downloaded and looked at any of the pictures that's sent. If anybody's got any pictures they want to show of their intersecting lines, there you go. 1 to 12. I think if I put a retractor on that, let's have a look. Oh, not too bad at all, actually. Not too bad at all. But you can score that. It's amazing. You can do 6 lines. And when we used to wear watches with hands, to actually do 12 dots and 6 lines that are perfectly radial turns out to be quite a challenge. So I'm looking at that at the moment amongst medical students, registrars, and expert surgeons. And my first analysis of this, there doesn't seem to be much difference. And I was expecting to see a graded difference between a novice and an expert in that 12 o'clock arrangement. And I'm not seeing that, which is interesting. But I have to look at it in more detail.
So my other observation was it's once again it's about situational awareness. So you're talking about the Enso, but what you weren't demonstrating was that behind your left shoulder is where it feathers out.
Yeah,
So
yeah,
yeah, but
yeah.
so you were blocking that
Yeah.
view.
Well,
I was aware it was there,
so
but
it's
you were
not a
talking
perfect
about
circle.
it, but standing in front of it.
Yeah, that's true. That is not a perfect circle. It's a
Yeah,
brush circle.
yeah.
And as I say, it's either open or closed, but it's done within one breath. And to get it totally perfect, well, you can't.
Well, no, that's the aim, is to
Yeah,
get it.
yeah,
It's the aim. So because we're all human,
yeah,
we'll not necessarily achieve that unless we are Michelangelo.
yeah. And Michelangelo drew a perfect circle.
Absolutely.
Well, I tried to find the story. I read it some time ago, but I couldn't find it when I Googled it. So perhaps somebody would like to correct me on finding the actual story. But the artist was requisitioned based on a single pencil drawing of a perfect circle.
So
Well, see you later.
does Sile wish to join us? Yeah.
Yes, welcome.
Hello, Prof.
Hi,
Good
Prof. How are
evening.
you?
Hello, good evening, Prof. Chris. Yeah.
So,
Yes, I think I have to show you something, whether you can see it or not. I don't
yes,
know.
yeah,
I
hold it
cannot,
closer to you.
I don't know
Yeah,
whether you can see it.
that's a circle of two. Yes,
Yes, this is the kitchen towel roll.
yes.
Yes, yeah. So, when you are showing us with the potato, the baked potato, and then changing the position, right? I think I can recall it. We have a one vaginal reconstruction. The lady with who had it, I think rectal tumor and invading and all that. So we did this together with plastic surgeon, Prof. Alizan and
Mm-hmm.
Prof. Siva, and myself assisted. So what happened that, like this one, he used the flap from the thigh and, put up the patch, the inside and out. And
Mm-hmm.
so that, when he did it, vaginal reconstruction, then actually this is very dedicated work, I would say, in order to get it this vaginal canal. Probably that might applies to that. I'm sorry, that I think transgender, that the
Yes,
plastic surgeon does that.
yes.
So I think our stitches will be like not only in that one direction, maybe in a multiple direction as well.
Indeed.
Uh, yes, this is a one
This is
example.
this is exactly where we're going to go next week, is to
Oh, I
tubes
see.
and joining tubes, because I
Okay.
want to get people to think about the
Sure.
body position and the
Yes.
arm position on a hemisphere. The
Sure.
next stage is exactly that, because
Oh.
each and every stitch, when you're going around a circle or a tube, does
Mm-mm.
require the same meticulous point, place, and rotate. And now
Sure.
we really have to think in 3 dimension and critically look at your alignment at each stage around the tube, as you say.
Yes,
And
Prof.
and the idea is to build it up iteratively so you can understand how this goes from a linear incision to a curved incision to a hemisphere. And now we're going to go 3 dimensional next week.
Yeah. Another issue is that because this is plastic surgery, so it's like there's quite a clean cut, the tissue. But I must say, I must tell you truth, sometimes we have a big baby with the, precipitated labor, and, we had it multiple, I'm sorry, vaginal tear, clitoris tear, you tear near the urethra, and so challenging, to anal tear. So it's like
Mm.
sometimes like for the big babies, then you can have it like all the tears are very, very haphazardly, So it's like we have to, of course, we have to adjust ourselves to accommodate all these tears, Then, of course, number one, you have to identify the tears. Then number two, you should not injure the urethra. We should not close the urethra when during our suturing. So we put the catheter in and repair it. And the third thing is that the good retraction.
Yes. You're
And
so
then
yes.
also the packing. We
Yes.
put a long gauze vaginal packing in order to see that particular area, and then do one after. Don't do everything at the same time. Do one after another, and plus good lighting.
Exactly.
So
So
yeah,
actually, you're dealing with a very, very complicated problem there, because it's not a
sure.
cube, it's at depth, it's three-dimensional, but it's not a clean cut. As you
No,
said,
bro.
a tear.
Tears, yeah.
So your three-dimensional perspective on your place point of the tape is changing each and every position as you
Sure.
repair it. And
Yeah.
that takes a lot of skill.
Yes, bro. So when we do patient on the lithotomy position, we use like previously I'd mentioned about that we use a rotating, moving chair. Sometimes we prefer like stand up and stitch up, Yes. And then we have to negotiate with the anesthetist, that sometimes we might need the patient to maybe put anesthesia, to make it relax. Otherwise, anytime you put the suture in, she bumps up, and it's like we have to adjust again. So good anesthesia is important, and then also make sure that you don't leave any gauze inside. You have to keep counting it, because this area is like very much distendable, and it can accommodate many gauzes. So we should not lose count, and we should not leave any single gauze, inside. So I think the gauze rule is important as well.
That is extremely true. And when you think of communication in theatre, it should be circular as well. Is that you're counting gauzes in and they're counting out, and you should count your sharps in and count them out, and have playback, circular feedback in that communication all the time. It's all part of the discipline.
Seeley, what you're discussing there is once again the next stage, which is the non-technical skills. It's situational awareness.
Yes, bro.
These are all plastic surgery problems. They're very complex, and you start from where you can see what you're doing. You use your anesthetist, the table, the light, moving up and down. So that's about decision making in the moment. So it's not about just sitting down, it's about moving from side to side so you can see it differently and do what's
Sure.
right. The
Yeah.
other thing to be aware of is that particular part of the body has an excellent blood supply. It heals very well, it recovers very well, and nature accommodates some of the errors which we as surgeons cannot repair. The body will take in its course.
Yeah.
Yes, bro. But the most important thing is that sometimes these areas can get, if we don't stop the bleeders, and then this hematoma can stretch into the pelvic cavity. It's like broad ligament hematomas. Yeah, so it's like you need to do a laparotomy and all that. So it's like, yes, of course we have to respect the bleeders as well, right? Sometimes it's into the ischiorectal fossa, it can go up to the broad ligament. So yes, in order to secure, yes, the meticulous hemostasis is very crucial as well. Yeah.
I
Do
think
you use tranexamic acid, Seeley?
Yes, Prof. We use that. We use a tranexamic acid. Yeah.
I think we will need a black belt session on hemostasis and aids for hemostasis at some point, and that'd be
Sure,
useful.
Prof. Yeah.
So
Okay.
this is my little hedgehog here. This is the potato. These, I think, are fabulous. These are little spaces for its tiles, and you can pop that in, and you can see that the 90 degrees changes in each part of my potato hedgehog here. And this is what we're wanting you to think about. So, Prof. Sile, Sensei Chris, thank you again very much indeed for your very valuable insights. Next week, we are going to take this to a three-dimensional perspective, as Prof. Sile has already suggested, tubes and how to orientate them around tubes. And I am not sure if our fellow Dr. John Rudd is still watching, but wish you well and hope to see you at home next week. Thank you, Dr. Apogita and Ayako, for giving us this opportunity to present. I ask the audience, please, to fill in their feedback forms. Do upload and try those diagrams. I'd like to see your attempts as well, and look forward to seeing you next week. And please pass the word around. I'd like to see more of you here. Thank you very much indeed, and we wish you well. Have a very good week. Hello, good evening, good afternoon, good day, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David Regan. I'm a professor in the Medical Education Research and Development Unit at the University of Malaya, Faculty of Medicine. I'm a retired cardiac surgeon. Welcome to the Black Belt Academy of Surgical Skills. And this evening, I want to pay a particular welcome to our regular viewer who happens to be in hospital in London. And I've just seen he has tuned in. So even on his hospital bed, he is watching the Black Belt Academy of Surgical Skills. And I'd like you, the audience, to join me in wishing Dr. John Rudd a speedy recovery and return to rude health. John, thank you very much indeed for joining us this evening from a hospital bed. That means a lot. I'd also like to thank IECHO for enabling us to reach across the globe. We are increasing in numbers, slowly but surely, and it depends really on word of mouth. Last night, I delivered a presentation to the ISSS Warsaw Division in Poland, and we're talking about the principles of stitching, much like we've covered to date so far. I'm also delighted that we are going to go face-to-face this Saturday in the Clinical Skills Unit in the Faculty of Medicine, and we have 14 keen students wanting to join the Black Belt Academy, some of whom have already bought their instruments. On Friday, I was actually in Centrepoint teaching first-year medical students the basics of stitching. I think the sooner you start with deliberate practice, the better you'll become. And it's my vision that when you start a surgical job, your hands are working, and then you can start learning about the crew resource management, error mitigation, and human factors in the non-technical skills of surgery. But like Dr. Rudd and I wrote a paper on situational awareness and driving. Well, this evening, we're going to continue our story of stitching. And the theme is round and round and rotation. You see, the circle throughout history has one of been humanity's most enduring symbols, appearing long before formal mathematics, in the natural rhythms of the sun and the moon and the seasons. Ancient cultures adopted the circle to express ideas of eternity, unity, and divine perfection. From Stone Age circles to Egyptian sun discs to the Greek belief that the circle was the most flawless geometric form. Across Asian traditions, the circular motif, such as the Enzo, represents wholeness, balance, and the harmony of all things. Enzo is the Japanese word and denoted with a Zen Buddhist symbol, usually drawn as a single spontaneous brushstroke, forming an open or closed circle. It is one of the most recognized symbols in Zen art and philosophy. It represents the moment when the mind is free to let the body create, often linked to insight and awakening. It represents enlightenment and emptiness. The circle itself conveys completeness and harmony and interconnectedness of all things. There's a wholeness and unity in the circle. Many Enzos are intentionally uneven or open, and Zen teaches us that the beauty lies in the imperfection or the authenticity of the stroke, because it is drawn with a single breath, and it reflects the artist's state of mind in that moment. Calm, focused, or distracted, the self is revealed. And I reflect on Black Belt Academy symbol. As you note, it is a circle. It is a brushed circle, and there are imperfections around the edge, because to get a perfect circle is extremely difficult. And the story goes that Michelangelo was asked by the Pope for a piece of his work to confirm his painting of the Sistine Chapel. And the envoy was brushed off with a simple paper with a perfect circle drawn on it and said, "Give that to the Pope." If you've tried to draw a perfect circle, you'll find it is extremely difficult, and we'll have a little exercise in a moment. The closed end, so, suggests completeness, totality, and perfection, and the open end, so, suggests openness, movement, development, and the idea that nothing is truly finished. And the brushstrokes here are incomplete, representing that is not truly finished. And can we ever reach mastery? See, Zen monks and artists often paint an Enzo as a meditative act, using a large brush with ink. The intention is not to produce a perfect circle, but to express presence, mindfulness, and freedom. As I said, it's usually done with a single stroke, and it has no beginning and no end. The circle reflects the continuous cycle of life, the interconnectedness of people, systems, and ideas. It also forms a protective boundary, marking a sacred space and centering attention. In this way, the circle becomes more than just a shape. It becomes a universal language, linking nature, culture, and meaning. Think about the circle of wagons drawn to protect the family and the community. But think about the circle of friends. Think about your circle of influence. And in the same way, the surgeon is part of that circle in being the team. We operate as one, a circle. And that is the philosophy of the Royal College of Surgeons of Edinburgh. Well, the importance of the circle is obviously really relevant when we think of the needle, because all needles are made on a circle. And we need to take the needle through the tissue on a perfect circle, such that if I did a tangential slice at any point through the path of that needle, I'd see a perfect circle and the thread sitting in the middle. If the rotation of the needle is poor, we will see an ellipse with the thread sitting in the middle, but the green space here representing that oozy wound, a spurting anastomosis, a microabscess, an infection. To get that is extremely difficult. And we previously said that 90 degrees is the fourth part of the circle. And it's that 90-degree alignment that enables you to align the needle. And it's the fundamental principle of what we do. We've previously said that in a linear incision, and you can try this yourself, we do three important things with a needle. We place the needle at 90 degrees across the wound. We rotate the needle back, we point it directly into the tissue and rotate it round, and we've got to come out equal and opposite on the other side. It's a simple exercise, and I did this earlier, and you can see that even to achieve the 90 degrees is very difficult. And I'm delighted to say that we have worked out a very interesting scoring system to enable us to check this. And again, like the circular incision, we will be putting that online to test. But the diligence required in this place, point, and rotate is required on every single stitch, every time, whether you're in deep tissues, superficial tissues, it is all the same. What we need to see as part of that rotation is a single dot or exit point of the needle on entry and on exit. And when there is a skid, you see it there and there and there. Well, I'm sorry. We've put this thing, this ubiquitous suture pad, through a CT scanner, and the Hounsfield units are 2,000 or 240. You cannot see the needle going in and out of this tissue because the hole closes up. You can't see it, but you can see it on the banana. Not only doesn't it feel like tissue, it doesn't show you where you're going wrong. And the Hounsfield units of the banana are between 40 and 80. The point of going in 90 degrees is beautifully illustrated here. I've rotated the needle back to point and pinprick the banana. And you see these little clean pinpricks. This is not 90 degrees. I've not rotated completely back to point in, and I've tried to enter the banana. And you can see it's almost chipped away. Compare contrast between there and there. It is significant. So the 90-degree alignment across and pointing in is important. And you demonstrated last week your ability to discern between 88.5 degrees and 90 degrees. That's how good you are at doing it. So I don't have to teach you to recognize 90 degrees because you can see it immediately. The other important thing about the placing, as we said previously, you can then visualize your spacing all the time. So that spacing should be regular. You can practice with a pen. And that's what stitching is about. It is regular. Rule up against there, and I've almost got, in those stitches, 5 millimeters apart. So we then went on from that to look at the banana and think of the vectors, and the vectors being defined by 90 degrees across the incisions. And I asked you to think about how you stand when you place your needle at 90 degrees across the tissue. In this situation, let me just turn the camera around so it's obvious. So in this situation, I place my needle down and try yourself standing on your right foot and the left foot. On the left foot, my elbow ends up a long way from my side. On my right foot, I'm turning into my elbow. So therefore, the movement and support of the scapula on the chest wall is significantly less. Remember, there are 17 muscles holding the scapula to the chest wall. So I'm standing on my right leg here, and I'm making the stitch. Again, I need to think, is it equidistant from the edge? There and there, it's not. And did it come out on the line? It is not. This side, which leg am I standing on? I'm standing on my left leg here and rotating the needle through. Is it on the line? Yes. Is it equidistant? Not quite, and a millimeter off. Remember that you take your needle, the needle's held by the tissue, and you can take your needle out to that point where you're able to pick it up gently, continue the delivery on the curve, and you should be able to use your needle again. I lost that before taking the next stitch. I'd have to replace the needle in the correct position. One is at the tip, two is on the halfway. There's no space between the tip of the needle holder and my finger, and note that angle, which marks the displacement of the wrist from the elbow. So and I think this is still upside down for me. That's better. We have realized we have to change our body position during that movement. So what happens then if you take an apple corer, this is a 2 centimeter apple corer, to a banana, and remove the skin. It's interesting, in a couple of the competitions that we've had, people have gone full thickness through the banana, almost laparoscopic style, which is rather amusing, and taken out a whole core. Now, to here, you need to actually think, where are the vectors? Well, the vector is, to be honest, on the radius, and it's 90 degrees at each part of the circle. Okay? There. It is 90 degrees as part of that circle. And the black belt skill is to take a needle in and out on that circle from inside out and stitch it with an over and over stitch without bushing the banana and having 12 perfectly radial sutures. Now, that 12 perfectly radial sutures as a visualization trick is rather awkward. And we'll try and demonstrate the difficulty, hopefully, and some of you have uploaded your pictures, and I'm afraid I haven't looked at them just as yet. But one of our questions was, can you put 12 perfectly radial sutures? And let's see, expand my view. So let's try, shall we? 1, 2, that's 12, 1, 2, 3, 4, 5. You see I've lost it and it's gone flat already. Okay, so I'll try it again. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. There. You can actually test this as well by simply getting a round object in there, putting it on, and seeing how many of them actually sit on the line. What's interesting watching people construct this, they start off thinking, okay, straightforward, and they go 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock, and then put bits in between. And as soon as you do that, you can see that my circle has ended up elongated or square. So the next skill that I've asked you to do is think about drawing 6 lines, 6 intersecting lines, okay? 6 intersecting lines joining the hours of the clock. That's one. That's 2. Okay, now we've got to think about 1 o'clock and